Good afternoon, everyone. This is Dr. Oliver Brooks, the 120th President of the National Medical Association, and I welcome you to this very timely webinar, Dual Pandemics, Climate Change and COVID-19 in North Carolina. Thank you to the Charlotte Medical, Dental, and Pharmaceutical Society for hosting this event, and Region 3 for also being involved. Give my regards to your new president, Dr. Brothers. On behalf of the national office, we are proud of the efforts that are ongoing in North Carolina for the NMA. Climate change is crucially important. I believe in this time of COVID and police brutality, there are some activities that sometimes get somewhat sidelined, but we cannot forget climate change. It is a fact that 70% of African Americans live within 30 miles of an area designated as having the worst air pollution. As the planet heats, we are more prone to having issues with overheating. We're less likely to have air conditioning. We're more likely to work in an area that doesn't have air conditioning. You get more fungi and more respiratory diseases. So we cannot forget climate change. And again, I laud you on this focus. The NMA had a webinar that I hosted with Dr. Brown's assistance also on May 2nd, Climate Change and Social Determinants of Health. So we are well aware, but the larger community may not be aware, and hence the importance of having this particular webinar. And I thank Climate Action Change, represented here by Elise Tolbert, for being involved with this. So again, my words will be few because there will be many words that follow. You have an excellent panel that will be presenting excellent information. You have an excellent moderator, and it is my pleasure to introduce our moderator. Our moderator will be Dr. Doris Brown, the 118th President of the National Medical Association. Her bio will be on the screen for you momentarily. I will say she rose in the military. She works with Brown and Associates, her own company, doing national and global health disparities. She retired as a colonel in the U.S. Army, and she has done much other work. She retired from the National Institutes of Health, the National Cancer Institute, where she managed the breast cancer portfolio in the National Division of Cancer Prevention. She's a graduate of Tougaloo University, and she's very proud of it. UCLA, which is in my neck of the woods, and she is a member of Trinity Episcopal Church, so she is a spiritual woman, she is ex-military, and she's an accomplished physician, so she has many talents. So without further ado, I bring to you Dr. Doris Brown.
Good evening, everyone. Thank you, Dr. Brooks, for that wonderful introduction. Again, I'd like to welcome everyone to this particular panel. It's very important as we talk about the dual pandemic of COVID-19 and climate change. And so I would like to just spend a couple of minutes telling you about some of the risk factors that many of us may not have considered. And since we are here in North Carolina as our headquarters, really climate change has been a big part of what's going on in North Carolina. And for those who do not believe in climate change and global warming, I would just like to say that the impact of climate change has a tremendous effect on North Carolina. Of course, you know that you are in the belt where hurricanes happen. Have flooding. You also have a rising sea level, and all of those factors add to your climate being impacted with what's going on. And of course, I did not bring anything in terms of polluted air, which is also a very important factor. And so if you look at this dual pandemic where you have climate change and COVID, we know that when we speak of COVID-19, we have in the past indicated that it occurs more likely in the older or more mature generation of individuals, but we're finding out that that's really not true. It is still true that it does impact more males than females. And of course, when we look at the race and ethnicity factor, it is known that African Americans and Latinos have 2 to 3 times higher incidence as compared to their white counterpart. And so in speaking about speaking about COVID just briefly, some of the other factors that are impacted by this and considered risk factors, and I know several of my panel members will go into detail on those risk factors, but chronic disease happens to be one of those risk factors that we know of. And of course, if you look at the underserved and people of color, they are more likely to have many of the chronic diseases. And when I say chronic diseases, I'm talking about the cardiovascular disease, cancer, respiratory illnesses such as asthma, diabetes, of course. And of course, we also have a risk factor because we are primarily essential workers. And coming from a medical background, yes, we are on the front line in terms of hospitals and clinics, but there are other essential workers, those that we depend on for our daily living, the mail carriers, the grocery store cashiers, the ones that stock the foods. So a number of the people that we depend upon, including those that pick up our trash that we hadn't ever considered. And then if you add in the underinsured and the uninsured that's not likely to have health care, that's going to be a risk factor for this individuals because they must be employed, they must go into work, and that's increasing their risk of being exposed. They also may have a lack of access to quality health care. Going on to speak about COVID, we will hear some of the other factors in terms of what you need to do, but all of us know social distancing being important, wearing our mask, and certainly hand washing very, very critical. But let's look at what's happening that's going on in the climate that's going to also impact us. And if we just focus on those particulate matters that really has a negative effect on what's going on, and then when you add that to this dual pandemic, things like the particulate matter, and that's things that we see in the environment. Lead, of course, that we all are very much aware of, nitrogen dioxide and carbon monoxide are all factors that are very critical. And so there were a couple of studies that have really talked about COVID mortality being exacerbated by particulate matters, and those are those little small particles that we know about. And this was a large study that was done in England, as well as a study that was done in New York when we were seeing such a high number of cases being admitted to the hospital. And so rather than spending a lot of time on that, let's talk about what we might be able to do in terms of getting us out of this pandemic so that we can extend our lives, but we can reduce our risk factors, particularly those that we are exposed to in our environment, or at least we can minimize the complications that would occur. So today, I'd like to introduce this esteemed panel that we have. Our first speaker is going to be Dr. Augustus Parker. And I should say that Dr. Parker is an OBGYN provider. He hails from Ohio, and he has a real legacy in terms of, I believe, 3 of his family members are also physicians. So he's a great love for the National Medical Association and for Ohio, and we applaud him for hanging in there with us, and again, focusing on the complications of what we have, particularly when we talk about pregnant women and the exposure to COVID. And then when you add the complication of the environment to that, it is going to be very critical. Dr. Parker's bio, of course, is on the screen, so I will not read all of that. He is a member of the Charlotte Medical, Dental, and Pharmaceutical Society, and we certainly want to welcome him. He will add many other important factors when he begins to speak on his presentation. I'm going to also introduce the other, well, I can do that in between. I was going to introduce all speakers. I do want to say before Dr. Parker starts his presentation that we are accepting questions in the chat box, and we would like for you to put those questions in. We will hold all the questions until all of the presenters have given their information, and then we will have a very lively discussion, and we welcome your input. So thank you, Dr. Parker.
Thank you, Dr. Brown, and good evening, everyone. I'm delighted to be a part of this discussion this evening. I think it's exciting to know that there's attention being brought to this. As Dr. Brown mentioned, I am an OBGYN, but my efforts have been in addressing health disparities, particularly for communities of color. So this is certainly important to me. Before I begin with my brief comments, I have a few slides. I'd like to provide an overview of what we're going to be discussing tonight. But as it relates to pregnant women, as a medical director with Novant, I wanted to make you aware of a few statistics and things that as we look at pregnant women and their infants. During the last few months during the pandemic, April 27th through July 5th, we have probably screened 3,646 women in our system, of which 64 tested positive. So that's a percentage of 1.8%. And of those women, we had 32% delivered by cesarean section, 68% vaginally. We had 2 that were preterm, and the highest percentage race-wise was actually the Hispanic population or Latino population at 66%, followed by the Caucasian population at 23%, and the African American population at 13%. So in addition to that, when we look at comorbidity, of those women that delivered, about 9% had asthma, but the overwhelming comorbid factor was obesity at 19%. One of the things that we looked at in our conclusions, looking at those women, was that COVID is commonly asymptomatic. The rate of infection is really no greater being pregnant or when the baby's born, and there's not really what we would call vertical transmission. And breastfeeding was allowed, as well as contact with the mother in most of these women. So it has seemed, our pregnant population has seemed to do fairly well with this. I want to give that brief overview as it relates to pregnant women, and I'm going to now move forward in my presentation. So this first slide says, I can't breathe. And, you know, all of us are mindful of what we've gone through with George Floyd, and we've never been so heightened in our awareness of how systemic racism has impacted all of us as it relates to the law enforcement community. And I wasn't trying to be too cute with this, but that's an example, I can't breathe, of being upfront and in your face with systemic racism. But at the same token, we've got to look at the long-term insidious effects that are manifest over a long period of time, and that is with this climate change, if you will, and global warming and that kind of thing. It's even a somewhat controversial construct, because there are still people that don't believe in global warming. So I had to do a little background information. I wanted to give an overview. Certainly most of you know about the greenhouse effect, and that's the warming of the Earth's surface caused by water vapor, carbon dioxide mainly, and methane gas. Most of that is caused by burning of our fossil fuels from our oil refineries, our automobiles, and our home appliances, and things like that that we use in our everyday life. This greenhouse effect, if you will, lets the sun in, but it traps the heat from getting out. And so as we continue over the years, and we've had this buildup of all of these fluorocarbons and greenhouse gas effect, the Earth's crust has gotten warmer and warmer and warmer. And with that, as I mentioned, it's primarily due to oil, fossil fuels, the burning of those, and the byproducts. As has been mentioned, it causes a cascade of events. The melting polar ice caps will cause the oceans to rise. And as mentioned, it's affected tropical storms and hurricanes, particularly in the South, as well as flooding. When we have this global warming, we don't have sustained winters that help control the growth and overgrowth of pollen and those things that can affect our respiratory health. The excessive heat can lead to droughts, which can affect our food sources. So there's a cascade of a number of events, and I failed to mention fires, forest fires. And just anecdotally, over a period of time, I think all of you have recognized the fact that our winters don't seem to be as severe in the North. I come from the Midwest. They don't seem to be as severe as they were. We don't get as much snow. We don't get as many cold days. And certainly all those things affect, have an effect, an anecdotal effect that I've noticed that seem that the Earth seems to be heating up. We talked about the oil refineries in cities, and the systemic racism that goes along with that has something to do with obviously where those refineries are and where we live. The health consequences we've mentioned: toxic fumes from power plants, the factories, vehicles, home appliances, the runoff into groundwater. A lot of these factories have byproducts of their processing that can run off into groundwater. And sometimes, maybe years later, maybe a generation later, you will see the effects of some of those toxins and cancer surges in those neighborhoods. Standing water from runoff and disease can cause disease-carrying mosquitoes to proliferate. So all these things have an effect. And certainly, these are in the urban communities, these densely populated areas where we have that heat island effect. When you live out in a suburban area where there's more greenery, green covering, pastures, and open spaces, the heat tends to dissipate. But in the heat island effect, asphalt concrete tends to retain heat. So not enough water, it can stimulate plant growth and pollen growth. I've already mentioned that about the respiratory illnesses that can occur, particularly in our communities. So where you live matters. People of color are 40% of the 60 million who live near a coal-fired power plant, even though we're still only about 13–14% of the population. 3.5 million people live in poverty, live in counties that fail in all 3 pollutant tests. So most of you are familiar with redlining, but this is part of the systemic racism that existed from the 1930s, where literally city conveners and planners drew red lines around certain African American communities. And on a map, when they drew those lines, it was primarily to prevent mixing of the races because of the presumption that there would be spread of disease. But in so doing, there was no investment in those communities. There was no building in those communities, and the property values fell. They were unable to create wealth through home ownership, and then predatory lending and some of those things took place to further devalue the properties. So only poor or lower income people could live there, and it was hard to escape those red line communities, which are still in existence today. Also, because those property values were so low, houses were foreclosed and abandoned, and factories would move in getting low price for those mortgage properties where they would build those factories because that was to their economic advantage. And certainly those who had resources, the non-minority communities, they had the resources to raise awareness, control the money, control public attention because they controlled the newspaper, the airwaves, and eventually print and visual media to ensure that their communities remained unblemished, so that this all led to inequitable distribution of those environmental burdens and left those burdens on the minority community. Environmental justice, the lower land costs and housing market I mentioned caused the biggest sources of to live in close proximity to those that had the biggest sources of carbon pollution. And I mentioned about the factories being built in those communities as well. The health consequences, we've mentioned some of those. Dr. Brown mentioned some of those, and we'll hear more about those. Heat stroke, asthma, heart disease, cancers, and chronic obstructive pulmonary disease. The cost to correct those, it's a high cost. And certainly there's been pushback from those that don't believe in global warming or how we distribute those resources, and those that have invested heavily in oil and gas industries that want to preserve their revenue from those. So in order to change some of those standards, the Clean Air Act, and it costs money. Higher emission standards cost a lot to change those factories and convert to nuclear, wind, water power, efficient motors, pumps, and generators, and more efficient cars. So systemic racism exists based on that historical perspective. So will the government pay for it? Will factories and power plants be built in suburban communities? You and I know that as long as there are no adverse effects on the families of those in power, nothing will change. And that will conclude my remarks, and I'll turn it back over. Thank you.
Thank you, Dr. Parker. And certainly we will have some questions near the end, but that is a very important presentation. Our next speaker is Ms. Elise Tolbert. She's an environmental health scientist. Are we changing this around? Okay, excuse me. We changed the order a little bit. Our next speaker is going to be Dr. Brothers. He is the president of the Charlotte Health, Medical, Dental, and Pharmaceutical Society. He is hails from, I guess, living in the Raleigh-Durham area, having received his education in Massachusetts, but he couldn't get away from home, so he certainly returned back to finish his medical training at North Carolina. He is a pediatric, I'm an oncologist, and I like to make people in my area. He's a cardiologist, a pediatric cardiologist, having completed his training at Emory University in Atlanta. And he is going to cover many of the things of COVID-19, but also may be able to tell us a little bit about the electronic health records and how our data may be stored, as he is the point person at his institution for the EPIC Physician Builder in Electronic Health Records. And I should say congratulations, as you just recently been elected as the president of the local medical affiliate for the National Medical Association. Welcome, Dr. Brothers.
All right, hello. Thank you for having me. So Matthew Brothers, I'm a pediatric cardiologist here in Charlotte. And so I'll be talking about from the perspective of children's health and climate change, and touch a little bit about COVID-19. So as far as a little bit of background, like we all know, climate change is one of the leading public health concerns across the world. Almost every international organization has some policy statement about how climate change affects their industry. Gradual increases in temperature that we all know as global warming affects the physical, the chemical, and the ecological features of this planet. And so it's easy to take the next step to know that that then affects the people and animals and everybody who lives on this planet. Now, all these populations aren't affected equally, and so communities of color are definitely disproportionately affected compared to others. And then lastly, children are more vulnerable today and will be more vulnerable in the future. The American Public Health Association talks about the vulnerability of children in three specific kind of categories. One is physiologic. So children and babies use more air and more water compared based on their birth, based on their weight compared to adults. Babies breathe faster. They drink more water based on their weight. We all know that children and babies in particular have an immature immune system compared to adults. So that may put them at risk for infection and other ways that the climate can affect them. From a behavior standpoint, infants and children are, of course, closer to the ground. So we think about air pollution. We also got to think about ground pollution. If kids are crawling on the floor of their house, crawling outside, potentially ingesting things on the ground, that raises their risk. Older kids spend more times outdoors. We'll talk about heat-related illnesses of kids who play outdoors in the summer and how that affects them. And then lastly, social. Of course, kids are dependent on adults for care. And so when you think about all these ways that children are vulnerable, the American Academy of Pediatrics talks about a risk category. And so they talk about primary risk categories have to do with the direct illness or injury from any climate or weather event. You could think about Hurricane Katrina and the morbidity and mortality directly related to that. Secondary risk is how health is affected by the change in the environment. So think of increased infectious disease related to vectors, or increased respiratory illness related to air pollutants or pollen. And then a tertiary risk is what the AAP calls a large scale consequences, things like loss of food, loss of water, population displacement, failing communities. And so they emphasize that in these different realms, children are at high risk of being affected by climate change. As a pediatric physician, I'm going to touch on 4 diseases. The first one is going to be heat illness. And so this graph shows a study over a 10-year period of heat-related injuries presenting to the emergency department. And as you can see, there is a clear increase over this time period. Of the patients who came in, about half of them were children. We know that children are at highest risk as adolescents. As I mentioned, they're outside in the heat. And then also children left in cars. And so the children left in cars are commonly infants. And so I believe that elderly have the highest mortality, but infants have the second highest mortality rate related to heat illnesses. And then lastly, poverty. And so Dr. Brown mentioned about a study that was done in New York City This is another one that looked at heat illnesses and saw that of all the deaths that occurred in New York City, literally all of them in this one study did not have air conditioning at home. And so just emphasizing the risk that at-risk populations have related to poverty, which is directly related to health, related to race. Next disease we'll talk about is asthma. Asthma is kind of a classic, commonly discussed childhood disease that's directly impacted by climate change. And so this diagram here just kind of illustrates the community level and the personal level that different factors can play that affect the asthma disparities. Things like socioeconomic status, which may lead to overcrowding and population density, outdoor pollutants, indoor pollutants, and tobacco exposure. All of these things can increase the risk of asthma and widen the asthma disparities. So next topic is COVID-19. I want to give a little brief overview of COVID-19 in North Carolina. We kind of reopened like most states in May and are seeing a sharp increase since the reopening over the last few weeks. Specifically speaking on the right panel there is the data broken down by race. And like most states, African-American population and the Hispanic population is hardest hit in our state. We recently had a mandatory masking mandate, and so I'm hopeful that these numbers will trend down. But when you think of COVID-19, it has also been affected by climate change and pollution. So there's a study out of Harvard that looked at the distribution of pollution across the United States and related that to the mortality rate of COVID-19. And what they saw was a clear increase that was related to the rate of pollution. And so these are the 5 quintiles, and as you can see, it goes up with increased pollution, which led them to a clear statement that says people with chronic health conditions, lower income, and communities of color are disproportionately impacted by both COVID-19 and climate change, and pollution is at the heart of both problems. The last disease I want to touch on is save the best for last, congenital heart disease. So as a pediatric cardiologist, I deal with this every day. And I commonly talk to pregnant mothers and they always ask, why does my baby have this condition? A lot of times I tell them that it's a random occurrence. But there was a recent study that showed that increased temperatures will raise the incidence of congenital heart disease. So about 1% of babies are born with congenital heart disease. And previous studies have shown that increased heat exposure have raised the risk of preterm birth and low birth weight. So a group did a study where they looked at weather projection data from NASA and the birth defect surveillance data from the National Birth Defects Prevention Network, which has several states that collect data across the country. And so they wanted to compare the defect rate from 1995 to 2005 and with a projected 2025 to 2035. And so what they saw was, as everybody would expect, is that they predicted for temperatures to rise in the United States. But what the scary thing and interesting thing was that they predicted a rise in congenital heart disease in the Northeast, the South, and the Midwest. Of those regions, they say the Northeast and the South will be most affected. They estimate that almost 2,400 babies in the South will be born with congenital heart disease, and about 2,500 babies in the Northeast will be born with congenital heart disease. You think about the distribution of the Black population, this will directly affect these communities. So, children are very affected by climate change. And as I was preparing this, I was left with, well, what can I do? The American Academy of Pediatrics kind of focuses on these categories. So, try to encourage all physicians to work to promote medical education opportunities regarding the effects of climate change. This is what we're doing today, trying to get the word out on the importance of this topic. Try to seek ways to reduce carbon and environmental footprint in our own offices and our own health facilities. Try to use anticipatory guidance as a framework. So we discussed gun control, we discussed seat belts. I think we should be discussing with families about what to do in an emergency, in a weather emergency. Educate children and families on emergency and disaster readiness. Advocate on a local, national, international policies to reduce greenhouse gas emissions. And try to help build a broader coalition across disciplines to address climate change at a local and national level. Thank you for your time. Dr. Brown.
Thank you, Dr. Brothers. I think I'm back on. Yes. Thank you so much. That was very informative. We are going to have lots of questions as we talk about the impact of many of those social influences on our children, and particularly the heat-related illnesses. So our next presenter is, just let me get my slides back up, Miss Elise Tolbert. She is an environmental health specialist, as well as a public health practitioner, and she serves as the partner engagement manager at the Climate Action Campaign. Elise has been passionate about health and climate for a long time, having focused on environmental and social justice in many of her things. She became interested in this work while she was at Tuskegee, working on the water quality outreach and testing program. And so today, Ms. Tolbert is going to bring us some wisdom about the state of North Carolina, in addition to other factors, because she lives by the motto of blaze your own trail, which reminds us of her responsibility to follow her heart and create a path for others to become engaged. Ms. Tolbert.
Thank you. It says that I'm unable to share my webcam. Oh, okay. I think I figured out the issue.
I can see it.
Okay. And now you can see me. All right. Good evening, everyone. I want to first thank the National Medical Association for having me here today. And I thank you all for your participation. We've heard a lot of really insightful information from our panelists before. And I just want to contribute to that with a little more background on the environmental health impacts and how climate change and COVID intersect as it relates to environmental health. So I'll start out with a little story. COVID-19 and climate change are two issues that may seem unrelated, but in the context of the United States, I could tell you a story about climate change and about COVID using the same storyline. Sit back, relax, get comfortable, because the story goes a little bit something like this. Once upon a time, there was a big threat that came to the world that would change life as we know it. All of the scientists and officials started to study this threat and realized that this thing was taking over the world, and it was so bad that something needed to be done about it quickly and immediately. In America and all across the world, they hastened to speak to their leaders, to their president, Congress, and Senate to warn them of the threat. Armed with science and with credible data, they knew for sure that their leaders would protect the people. Instead, their leaders called the whole thing a hoax, said it was fake news, just an attempt to spend lots of money on a liberal agenda, and did nothing about it. Doing nothing about it, the issue started to get worse and worse and worse. People were dying. It was very sad, but even sadder because not all people were impacted the same. You see, before the threat came, the people didn't all live equally. Black people in the nation were facing hardships because they had been oppressed for a long time because of the color of their skin. At the time, Black people were more likely to live in places with more environmental pollution. For example, Over 70% lived within 30 miles of a polluting plant. And of those, those things pollute a lot of bad chemicals into the air that affect Black people's breathing and their health. When it came to this big health issue, Latinos were 4 times more likely to have to go to the hospital. Blacks were 4.4 times more likely to go to the hospital. And Indigenous and Native people were 5 times likely to go to the hospital because of the big health threat. Black people face these issues in relation to their water, their air, and many other features of their environment. It wasn't because Black people didn't want to enjoy the benefits of a pollution-free, carefree, healthy, happy life, but because the nation put a system in place with millions of microsystems that kept the Black people from developing wealth and other tools of prosperity. Anyway, this big threat was killing people, killing Black people, Hispanic and Indigenous people at a much higher rate. And the people screamed out for their lives and started to fight back because their lives matter. But meanwhile, there was no systematic change, no systematic action, and the issue got worse and worse and worse. There's no the end because the story isn't over. And what we do now informs how this story unfolds. This is the story for both COVID and also the story for climate change. And that's because our nation has known about climate change for many years and yet has taken no aggressive action, implemented no aggressive action to address climate change. The same goes for COVID. Our nation and our president knew about COVID. They know about COVID, and they know that it disproportionately impacts and is literally disproportionately killing Black, brown, and Indigenous people, and yet have taken no serious, concise efforts to remedy that situation. So there's a lot to learn in the intersection between COVID and climate, because while COVID is an infectious disease and climate is inducing changes in our environment, the way we respond to them, the way we react to them, and how we protect people has a lot of similarities, and there's a lot to learn in the process. What we know is that there are a myriad of health impacts that are associated with climate change. I won't speak too deeply about these because the previous speakers have spoken in more detail, but we know that with climate change, there's an increase in waterborne and foodborne illnesses and diseases. We know that there's an increase in heat-related diseases. I am sitting right now in Tuskegee, Alabama, my home, and we know that in the Southeast, the science has predicted that we'll continue to see a rise in temperature. And a rise in temperature isn't just something hard to deal with because it's hot, but a rise in temperature can be deadly. It's deadly for those people who work outside. It's deadly for people who don't have access to air conditioning or who have access to air conditioning but can't afford to use it because they're trying to stretch a dollar. So increase in heat-related deaths is a really serious issue. We know that there will be increase in allergic illnesses like asthma and hay fever. We've seen that the span of the allergy season has increased. We know that there will be a difference in the geographic range of disease-curing insects and pests. And this actually does relate to COVID, because as we become a more globalized world, we are able to enter places and spaces that we weren't before and interact with nature in ways we weren't before. We're also able to move goods and services from one continent to another, move people from one continent to another. And so that changes the way in which vectors and diseases move around the world. For instance, if this was 1,000 years ago, I highly doubt that this infectious disease, COVID, would be able to move from one continent to this continent as quickly as it did. And so we, as humans, actually become vectors for carrying diseases that we can move and give to each other. In North Carolina has been subject to a number of issues with hurricanes. North Carolina is a coastal state and has been subject to issues with sea level rise, such as sunny day flooding. Sunny day flooding is when there will be a flood on a sunny day because of the sea level rise, and with extreme heat. And extreme heat has been one of the top contributors to hospitalization rates, emergency department visit rates, especially during the warm summer months. It again particularly affects the agricultural workers. North Carolina is a heavily agricultural state, but it also affects those without air conditioning, those impoverished, athletes, people, in those positions. So what I'll talk about right now is air and health. Air pollution, as I mentioned before, over 68% of African Americans live within 30 miles of a coal-fired power plant. And coal-fired power plants, if we don't know what a coal-fired power plant is, we don't know what it emits. But coal-fired power plants and other polluting facilities as well, like landfills and coal ash landfills, and in North Carolina, a big issue is concentrated animal feeding operations and pipelines. Many of those happen to emit a number of chemicals into the air, like heavy metals and particulate pollution, that because of their size and their chemical makeup have the potential to do a lot of damage in our lungs. And it doesn't just end at our lungs. Exposure to those pollutants can also impact our cardiovascular systems and other systems. Exposure to air pollution in North Carolina and in general can lead to issues such as premature deaths, cardiovascular disease, asthma attacks, lung cancer, and so much more. And as one of our speakers said before, Dr. Parker, that redlining and the locations in which we live play a major factor into where and how we are exposed. So, for instance, there's a community in Charlotte that has been, it's a historic community that now is the home of 3 major freeways, I-85, I-77, and another major freeway, interstate. And this is a historically Black community that for many years did not deal with this pollution, but became a Black community because of the redlining, and the segregation, and is now struggling to improve their air quality because they see how the poor air quality impacts their health. As Dr. Brother said before, there's an intimate relationship between climate and COVID in terms of air pollution. Studies have found that places with higher air pollution before the pandemic also have statistically shown to be places where there is a higher rate of COVID deaths. And when you think about it, it makes sense. COVID is an illness that particularly impacts the respiratory system. And so if you live in a place where you breathe in poor air each and every day over the course of years, your respiratory system is already vulnerable, it's already compromised. And so it's important that we have high quality air, because in the situation where we have low quality air, we become more vulnerable to layered issues like COVID. So we've heard a lot about the issues, because the issues are numerous, honestly. But what I want to talk to you about a little bit more is the opportunity. Right now, Congress is pouring more money into this economy than they have poured in my lifetime, at least ever, at one big time. From the first CARES Act to the second CARES Act to the HEROES Act, we've seen that we're at a point where we have the opportunity to remake our economy, to remake our nation, to ensure that we not only help people get by for the meantime, but that we improve the conditions in which they live in so that they can live in a more resilient, thriving, healthier community going forward. And so Representative Grijalva and Representative McEachin wrote a letter that proposed programs that would help us to not only get through this hard time, but come at the end in a better position. Some of the programs that are listed in this letter include the Drinking Water State Revolving Fund and the Clean Water State Revolving Fund. I'll skip down to the next column. The Low Income Home Energy Assistance Program, the Weatherization Assistance Program, the Diesel Emissions Reduction Act, the Environmental Justice Small Grants Program, Superfund site cleanups, brownfield programs, more environmental enforcement, and community development block grants. And I'll go through just a few of these because these are really important programs. As we've seen before, a part of why COVID has hit Black and Brown communities hardest is because we had a lot of existing vulnerabilities. We had existing health vulnerabilities. We had higher rates of cardiovascular disease, higher rates of diabetes. We lived in places that made us more vulnerable, poor quality housing. And when the pandemic hit, we lost a lot of jobs. It was a hard economic toll. And even as our economy is starting to recover a little bit, Black people are still kind of getting the short end of the stick in terms of economic recovery. We have not been hired back at the rate that other people have. So programs like the Low Income Home Energy Assistance Program, for instance, are really valuable for stimulating, because these programs help to give funding to people who have low income so that they can pay their bills. Earlier, we talked about extreme heat and that there are people who have access to air conditioning but no money to fund it. We may all understand, the days of making a dollar stretch. And so this program helps to make people more resilient in the face of climate, both now and going forward. The Weatherization Assistance Program is another one that does that. There's a significant portion of our Black population that lives in inadequate housing. The walls are leaky, the ceiling, and so they are not able to. They're not able to keep adequate air conditioning in or keep cooling in. These programs help for that. And another one I'll just mention is the Environmental Justice Small Grants Program, which is important because it allows the government to give money to communities to decide their own resilience, decide what they want for themselves. So this is a really great opportunity in the midst of this crisis, in the midst of this sad time, for us to pause and say, hey, we need help now, but we also need help going forward. And what has been great is that the National Medical Association has signed onto a coalition that is now advocating for these priorities, using their unique and important voice as Black doctors. I'll go quickly through the rest. Again, the opportunity when we think about air pollution comes from these polluting sources. So what we really need are sources that don't pollute and that provide extra benefits for us. Solar and wind are great opportunities for African Americans, both for employment, but we don't just want jobs, we want to pioneer and entrepreneur. So they're great opportunities for employment for African Americans, but also great opportunities for investing, for starting businesses and things of that sort, and for reducing pollution. Clean, pollution-free energy saves money, especially for the consumer. It creates businesses and jobs, and can do so for African Americans because of the diversity of training needs. And it improves health, which is our bottom line here as doctors. It takes the pollution out of it, reduces the amount of pollution that we're putting into the air, reduces emissions, and can improve health. I'll skip this slide for the sake of time and just talk about the path forward. So I've mentioned here that we have an opportunity to advocate as the next stimulus package comes out for what we want this money to go towards and what kind of future we want to create for ourselves and for our families. So the path forward really looks like creating healthy Black futures, and that requires attention and action to protecting the environment and spaces where we call home. Our environment is everything. It's where we live, work, and play, hang out with our friends, our children, and whoever else. It greatly influences our health status and outcomes, especially for communities of color, where we often live in places where we're overburdened by environmental injustices. So what you can do is National Medical Association has signed on to this coalition. They, and Dr. Brown, I know, has been, committed to getting funding to help our communities. You can contribute by writing a letter to the editor or an op-ed, or participating in National Medical Association's legislative activities, so that you can also raise your unique voice as a doctor to say, look, I'm seeing patients who are sick because of their environment, and I'm over it. It is time for priorities. It's time for you to prioritize our communities, our life, and our future. And who better to do this than you all in North Carolina, where North Carolina, Warren County was the birth of the environmental justice movement. So I know that you all are fighters because you all have been fighting in North Carolina for a long time. And finally, I close with the goal is to create resilient, thriving communities. I thank you for your time, and I thank the National Medical Association for allowing me to speak today. Thank you.
Thank you, Ms. Tolbert. And I want to thank all of our panelists. I know on the program, you saw that Dr. Gray was going to be our final speaker for this evening, but there was a message that he is unable to join us. And so we are going to go right into our question and answer period. I will start off by asking all of my panelists to activate their webcam to come back on, and I will direct my first question. Thank you so much. And I should say, before we go into this, I'm going to ask the audience to give everyone a virtual clap. I don't know, I think in the chat box, there's a little clap that you can raise your hand or put that little clap applaud for a wonderful, wonderful presentation. And so getting ready for some questions here. I have several questions in the box, and I think there's others coming in. I'll put my glasses on so I don't miss the point. The first question goes to you, Dr. Parker. Why was there such a large discrepancy in the number of women that were tested? I think you mentioned about the pregnant women and you had screened X number. They wanted to know why was there a discrepancy in the number tested and the number of positive tests?
Well, I think one of the things is we're screening all pregnant women, and so we have a large system, and the other hospitals are doing that testing as well. I think that actually the percentile of positives out of the testing that was done was 1.8%, so fairly low. Yeah, I don't know that indicates that there's a protective effect in being pregnant, but it's reassuring that pregnant women aren't disproportionately, we aren't seeing those same rise in numbers as a selected at-risk population at this time. So I am reassured by that. And so I can't explain it particularly at this point, but I am reassured that we haven't had that as a risk population particularly, and neither has there been particularly risk in the neonate as well.
Thank you. I just wonder if whether there is, and I don't know of anyone that has looked at that, is there variability in the tester and the test, whether there's a positive correlation to how deep, if you're doing the nasal swab, that swab is in terms of positivity versus one that is not so deep and a negative test. So is there any, and any of my panelists can comment on that. I've often wondered that some tests are positive and they get retested and they're positive. They're negative the first time and then they're positive the second time. Is that related to variability in the tester?
Yeah, we just had, it's funny you mentioned that, we had our, the Charlotte Pediatric Society had our meeting last night, and it was led by 2 infectious disease doctors, and they touched on exactly what you're saying, that there are different ways to get a sample. Used to be the one that goes really, really deep into your kind of cavities there. And what they showed that the one, just the mid pharyngeal one, was as sensitive and specific. Some of the testing can be oral, and so there are different ways to get samples. And so that's one thing. I know in our health system, Dr. Parker and I are in the same health system, I think we're doing mostly mid pharyngeal. You don't have to go all the way back. But a big thing that happens is that it depends where you are in your curve. If you were tested, so if these pregnant women are asymptomatic, are they asymptomatic because they don't have it? Are they pre-symptomatic and maybe they'll be positive when they leave the hospital? So there's, all the different things we learn in medical school about epidemiology and infectious disease all come to a head with this condition. So there are a lot of reasons why people test positive for the first one and then, or negative for the first one, then positive for the second one, and kind of vice versa.
Okay, let's see, another question. This is, Dr. Parker, this is mostly a statement. Is it far-fetched to assume that the religious community, and they put in parentheses, the far right, believe in the notion that rewards will be given in heaven, so therefore forego any of that responsibility to take care of your health on earth? And this person is saying they don't understand why the elected officials are not more responsible in addressing climate issues. Any comment?
I'm not sure that I can respond to people's motivation or lack thereof, particularly in terms of following the science. The flip side of that too is that sometimes we have to be mindful of having that important support from our religious communities, that we can't simply pray this away. That and I'm very much engaged with several of the pastors in our communities here in Charlotte that are very supportive of the initiatives taken by the medical community and how we tried to work together in addressing those concerns. So they have been very engaged in reaching out to their congregants and their communities to petition for testing in their communities, which the hospitals responded to, as well as understanding the importance of the science and working science and religion together. But I can't speak on the motivation or lack thereof of other people outside of those communities.
Yes. Okay. Ms. Tolbert, while doctors may see themselves or ourselves as being environmental justice advocates, but each person's environmental exposure directly impacts their health. Given this realization, how do you see your role in advocating and pushing for a healthier environment?
Thank you. Well, I'm not a medical doctor, not a medical professional. I do have a master's of public health. So I work in public health. but not as a practitioner right now. But through my experience in organizing doctors, especially working with the National Medical Association, I see that doctors are strong validators for the health of their patients. That when doctors talk to legislators, the legislators listen, especially when they come together, because you have a unique experience. And when you can connect something that I think with climate change, it's really hard for people to connect climate change to really to any facet of our society. But when you as a doctor can connect climate change to whatever you're doing, or if you work in education, or if you work in any other field, business, financial sector, connect climate change to what you're doing, it helps to make a strong case for your legislator to take action on climate change and shows us what you want to, what needs to be done. For COVID, I really feel like we just all have to make our voices known. This is really taking the world by storm, and it is utterly disgusting how horrible the state and the government has delayed testing, delayed every measure necessary, even from, real support. I know my father's a Black business owner, for instance, and he and so many others have not got the support to adequately close so that they can, keep the population safe. So we really all have to make our voices known and heard in terms of getting a comprehensive strategic response for COVID, but also for climate, because climate exacerbates COVID and COVID exacerbates climate. And this is a long answer, but I'll just say one thing I didn't say before is that we are in the midst of hurricane season, and our general strategy for hurricane season is that if a disaster hits, we get everyone in this big Superdome together, and we have more disasters like hurricanes because of climate. And imagine 100,000 people being in a Superdome together with COVID, like how do you prepare for that? That's a mess. So there is a lot of intersections in terms of our response to COVID and climate. And we really need to ask the people, our administrators, to be responsible and thoughtful in this process.
Thank you. Next question, Dr. Brothers. With the increase in asthma that we're seeing, is there a correlation with obesity, which is a national crisis?
Yeah, that's a good question. I don't know if we know, to be honest with you. Particularly pediatric obesity is a big issue. Again, another disease, childhood disease that disproportionately affects African American children. Thankfully, I think with some of the initiatives that were taken by the Obama administration and Michelle Obama trying to improve school lunches, there was some reassuring data that the numbers were trending down. And so it's going to be scary to see what kind of the numbers look like in the past few, 4 years. What's been interesting with COVID is that, everybody thought that it was underlying respiratory diseases like COPD and asthma would be the biggest comorbidity related to mortality. With COVID, it's been obesity, has been kind of the major player. On the call again yesterday for all the pediatricians in our city in Charlotte, they put a list of some of the kids who were admitted and the comorbidities, and about half of them were obese. And so that's played out in children as well.
Okay. Dr. Parker, environmental justice recognizes that there are a broad spectrum of issues that disproportionately impacts the Black community. As a healthcare provider, what is one environmental injustice that concerns you the most, and how do you see this manifested in your patients' health?
Well, I think one of the things that impacts environmental justice is the imbalance of the economics. As you know, North Carolina, unfortunately, is one of the states that ranks highest in the lack of upward mobility out of poverty. And I think, I hate to bring money into everything, but it is an equalizer. And I think that's one of the major injustices relative to all those things that would create opportunity for people to move out of communities or have a voice and have power to get better jobs, better training, and that sort of thing. When I think about the growth of this great city of Charlotte, and I see a lot of construction and buildings going on, I've said this in a few places that I wish that we would not allow these builders that are going to make millions, if not billions of dollars, whether it be the financial industry or whatever else. I wish we wouldn't allow them to build, get a building permit unless a certain percentage of the workforce had to be employed from our communities. And not just employed, but trained. Not just trained, but provide transportation to get to the job for that training. Not just transportation, not just job training, but also childcare for those people. That's the only way that we're going to change the injustices that lead to some of these systemic problems, is through economic change. So that's one of the biggest problems I see, and also one of the biggest opportunities.
Okay, thank you. Here's a question generally for any one of the speakers. Coal ash is a major issue in North Carolina, and it affects groundwater and other water sources that probably contributes to making cancer the #1 cause of death in North Carolina in 2019. Any comments? Any of my speakers want to comment on coal ash?
I can comment on coal ash. I've become a little passionate about coal ash. So before coming to where I work in DC, I used to organize with communities in Alabama. And if you look up Uniontown, Alabama is another one of those small, Black, very poor communities that has been burdened by a coal ash landfill. And I've spoken with people directly who have said that they know that their loved one had these multiple cancers or things of that sort because of coal ash. I've also been working with the North Carolina Environmental Justice Network, who I would recommend you all connect with. They're doing really great work, and coal ash is one of their issues. One of the issues with coal ash is that there's very loose restrictions on how these landfills are set up. First of all, the ash from the coal, which is basically a byproduct of producing coal energy, is very toxic. It contains almost everything that you don't want in your body and that you don't want in your water and that you don't want your fish to be swimming in and things of that sort. But some of these landfills are lined, but many of them are unlined. And if they're unlined, then it provides an opportunity for the chemicals to leach into the soil and to get into the groundwater. And particularly for rural communities in North Carolina, some of the, traditional farming communities where people's grandparents and great-grandparents have had their land for years near coal ash landfills, they got their water from well water, living a more simple life, and they're not able to do that anymore. The ash also is like these small dust, so if it's in a dry landfill, it can blow in the air. They're not able to sit out on their porch anymore, so it not only impacts their water, but impacts their air quality too. And it's a big issue in North Carolina. Big issue in North Carolina.
Okay, thank you. Dr. Brothers, do you have data on the impact of air pollution on COVID-19 associated pediatric inflammatory disease in North Carolina or nationally?
I don't. The pediatric inflammatory disease, multi-system inflammatory syndrome related to COVID, MIS-C is kind of the abbreviation we use, is a complicated disease that we're learning a lot about. And so we know that COVID is affecting children overall from a respiratory standpoint less than what we would think, especially considering all the kids who have colds and flu and any other time. What's been interesting is that they've had kind of an inflammatory response that's kind of manifest in basically 3 different diseases. One is something called Kawasaki disease, or really what they call Kawasaki-like disease. And that's basically a vasculitis where that affects the coronary arteries of the heart. There's the MIS-C disease, which is a multi-system situation where it affects any organ really. And then they can have kind of direct involvement of their heart as well. As far as pollution related to that, I have not seen any data, probably because it's new, so new that there hasn't been enough studies to even kind of report that yet. At this point, things are just kind of case reports from different cities who've been managing it on their own. So it'll definitely be interesting to see how pollution and the environment have made certain populations at risk for that as well.
Okay. Another question. What is the time frame for testing? The optimal time frame for testing, is it at least 3 to 5 days after exposure? I think it's a little difficult because we don't know when many people have been exposed, but I will let the panelists comment on that. We have a lot of symptomatic
on the
people
call yesterday, they said about 5 days was fair. It was 5 to 7, 4 to 6 is kind of depending, but in that kind of range. And so what they emphasized was not.
Exposed.
Say it again.
If you know you've been exposed to someone with it.
Right. So if you know you've been exposed, if you rush out the very next day, oh no, I was exposed, and you get tested, the antigens that your body have produced are not high enough to be detected by the test. And so giving it several days to get to a detectable level is what has been recommended.
Yes. And I think from data from Dr. Fauci indicated the large number, maybe 2 million people that may be asymptomatic and carriers and don't know that they have been exposed. So we have a large population there that we really have to get concerned about. The next question, what is the update on COVID-19 in North Carolina? I think, Dr. Brothers, you may have had some data on that.
Yeah, hold up. Yep, I can pull up kind of the images that I had. And so we are on the rise like many other states. I think our overall positive test, all depends. And so the thing that I feel is probably the best measure of how states are doing is positive test rate and hospitalizations. We all know, and it's been kind of, the message has been a little bit mutated by kind of public officials, how they report that increased testing leads to increased cases. There's some truth in that. So really, how is it affecting the communities really depends on increased hospitalizations and test rate and, of course, mortality. And so the test positivity rate in North Carolina is about 8 to 9%, I want to say, in the last few months. Overall, it's closer to like 7%. We weren't that hit that hard in the very beginning, but since everything's opened up, and I think people had a false sense of security, the numbers have really skyrocketed. So there have been a total of 75,000 cases in North Carolina. That's out of, and then 900, almost 1 million negative. So like I said, it's not as bad as some of the other states that have been hit. I saw a number that I think Florida currently is out about a 20% positivity rate on their tests. And so that's incredibly high. That's like how New York City was. And so, masking everybody, what I tell my patients, I treat masking like I treat talking about seatbelts and talking about gun control. Wear a mask, tell your friends to wear a mask.
Yes. Okay. In addition to education, how can a frontline physician make a difference in climate change? For anyone who wants to speak on it?
I'll reiterate what Dr. Brothers just said. I think we have to be examples of the practice that we want to see. So certainly in all our offices and our systems, we have tried to emphasize social distancing, hand washing, and masking. And I think that's primarily one of the things. Even when I see people out on the rare occasions that I'm out, when you see people, there's even the proper way of wearing a mask. It's not wearing it around your chin, and it's not wearing it off your nose. And you don't have to be a physician, but if you pass on those messages, one of my biggest advocates that keeps me in check is my spouse, my wife. So she makes sure I, you know, and as a healthcare professional that engages the public, we have to be mindful of how people are looking at us and what they see. So I think there's education that can be done on a case-by-case basis when we engage people. You know, as we started to transition back to seeing patients in our clinics and offices in different phases, you know, there was a high percentage of video visits at first and teleconference visits and e-visits. But as we've transitioned back to opening up our offices, we've done things like kept patients in their cars to be called in. We've limited visitation in the hospitals as well as in our clinics, and we've taken out magazines and space and taken out seating in our waiting rooms. So there's a lot that we try and teach and emulate to the patients and how they should be acting at home. It's very challenging, particularly in our communities where we have dense populations, where we have families that are living together, where we are economically challenged because of loss of jobs and wages, for people to be able to have the flexibility to live their normal life. And so as we come together to support each other in these densely populated communities, it certainly puts those persons at risk. So I think it's on a personal level. I think educational talks such as these, whether it be with church groups, social groups, and others, to emphasize the importance of following those tenets are things that we can do as individual physicians.
Okay, we're getting close to the end of our time. I do have a couple of more questions. Dr. Brothers, what grassroots programs can you share that are models for helping Black families change lifestyle patterns around nutrition, health, mental health, and well-being, targeting children?
Ooh. You know, I don't know any grassroots organizations, but I know that there are, every city has resources to help. I think starting with your pediatrician is probably makes sense. Dr. Parker mentioned kind of the church community. I think they're also plugged in, and so I think that's what I would probably recommend. I don't know of any specific in North Carolina. It was interesting. My mother has done a health disparities nonprofit in Durham, North Carolina, for 30-something years at this point. And so this has been an issue that we have known about for a long time as far as health disparities in our community, and something we'll have to keep working towards.
Okay, Dr. Parker, can you discuss the unique challenges for Black pregnant women, or pregnant Black women, during this pandemic? And are Black women more at risk as it relates to COVID?
Well, I think first we have to back up just a little bit and say that the incidence of maternal morbidity in this country is extremely high, particularly for people of color. African American women are more than 2.5 times at risk of dying in the hospital from pregnancy-related complications compared to their white counterparts. And some of that goes back to some practices of implicit racial bias in terms of how we listen to our patients, how we make diagnosis, and how we recommend treatment and referral when appropriate. A lot of those issues are related to hemorrhage-related disorders that occur in the hospital. And then to take it further, we have to institute programs that teach physicians and providers how to be sensitive to the unique needs of our minority populations, and how to listen and empathize and not brush their symptoms off. The other thing is we have, unfortunately, a high rate of infant mortality for the state of North Carolina. Again, 2.5 times greater than our white counterparts, and that gap really hasn't closed over the last 20 to 30 years. I think more education. We certainly have to have more providers that reflect the population that we serve. So we have to have initiatives with getting more providers into our school and training So because there's that element of trust and mistrust, and then again recognizing the unique capabilities and perspectives that our patients bring to us, and how we engage and listen to their signs, symptoms, to be able to better treat them. To
Okay.
answer the question, does that pose a greater risk for people of color? I certainly think that it does. But again, fortunately, we've not known that COVID in and of itself has tremendously adversely affect the pregnant population or neonates. But we are disproportionately represented there with the Hispanic population in particular.
Okay. Thank you all so much. I will
Dr.
provide.
Brown, can I ask a question?
Yes, go
Elise,
right
sorry. Elise, the story you read, was that a book?
No, I just was
made it
talking.
up.
That should be a book. That was very good. That was very good. Okay,
Okay.
sorry.
I would like to
Thank you.
just provide some closing remarks. There was one question that was left that all of us can answer. How long will it be before we have a vaccine? Not in 2020, so don't put your hopes on that. Okay. We know that air pollution increases the severity of health outcomes. And so there is a direct correlate between pollution, particulate matters, and ozone as it relates to acute respiratory disease syndrome, which is a major part of COVID. And it's important for us to enforce whatever existing regulations on air pollution that we have. We must speak with our legislators to make sure that they maintain them and continue to enforce it if we're going to protect the health of ourselves and the future of our country. We've heard tonight the factors that influence poor outcome, whether it's related to COVID or to air pollution, and that is more males than females, and of course the new statements that started off of anyone over the age of 60 is not holding, because we're getting young teens, and then there was even a preteen that was found to be affected by the disease. When we look at mortality, the racial and ethnic profile continues to remain that African Americans and Latinos have the highest death rate, the highest incidence rate. And again, yes, we have those related conditions that are there, but a key factor that we haven't found a lot of talking about, and that is the associated inflammatory response that happens in the body when it is exposed to COVID. That same kind of a factor we have when you're exposed to the particulate matter that's in our environments. And when you have a mortality rate that's 33% or 35% in African Americans, when we only represent about 13% of the population, and the Hispanic numbers at about 8% when they're only 14% of the population. And that number is increasing, particularly in Texas and in Florida. But the question is, what can you do? So the take-home lesson is to recognize that climate change is everybody's problem. It's not the government's problem. It's not the EPA's problem. It's all of our problems. So not the government, not a scientist can fix it. We have to all work together. And this is the same thing that you hear about COVID-19. We're all in this together, and we can fix this together. So we have to look at our lifestyles and going about to make those changes. We have to start to conserve in terms of our heat and our cooling, particularly now that it's getting very hot. You got to take a little time with the work running those air conditionings all the time. You got to conserve the hot water. 17% of the energy that is used to heat water in our homes, and that's really high. We have to think about changing that. We have to think about recycling. We have to conserve our use of cars so that we're using less gas. We have to reduce our waste, and we have to maintain the fact that COVID-19 can be prevented if we start to practice those guidelines that are there. Social distancing can really save lives. So wear your mask, maintain social distance, wash your hands often and frequently, because the greatest public health challenge in the 21st century is climate change. So we have to have action to reduce that climate change and improve our health, just as we must take into facts that equity must be central to climate change. And when I talk about equity, it is a combination of all the factors that you've heard this evening, whether it is the underlying health condition, whether it is the zip code and where you live, whether it is access to health care, what is the high exposure that we're seeing in our essential workers, and then you have the underlying risk factors that may be related to some genetics. So it's a multifactorial COVID risk factor and environmental change risk factor that's there. So the vision for a healthy people is healthy places on a healthy planet. And this may be our only home, and so we must take care of it. I want to thank our presenters. I want to thank the audience for their questions, and we'll give ourselves an applaud. And again, thank you very much. One last statement from Region 3's chairperson said that she wants to know if you are all available for their fall winter Region 3 webinar series. So she probably will be contacting you. Thank you all again and have a good evening.
Thank you.
Thank you.